Hi guys, so for my paper, I wanted to look more in depth into end-of-life care. That's something that's always interested me. So I kind of start off talking about prevalence. One source that I found says that approximately 45,000 infants, children, and adolescents die in the U.S., and half of those deaths occur in children less than 1 year old. So that kind of sets up the need for this kind of care. The first thing that I talk about is care planning. It's important to do this ahead of time if you are able to. Sometimes you're not because unexpected things happen. Changes in a patient's condition can occur really quickly. But if possible, establishing a care plan that the family and patient are on board with and the care team is on board with, making sure that everyone is collaborating. That's one thing the child life specialist can make sure is happening if that opportunity is there. So I kind of go into talking about all of the decisions that have to be made near end of life. And one of those decisions is where the patient is going to die. So if there is time to make this decision, children can die in their home, in the hospital, or at a care facility. A majority of children die in the hospital in an ICU or pediatric ICU or PICU setting. But the children that don't die in the hospital die at home or in a care facility. So there are benefits to dying at home, like being in a familiar environment, having the resources there that they're used to, activities they like, books, movies that they're interested in, things like that. One downside to this is that not everyone is able to die in their home, and that might be due to their medical condition. It might be due to not having time or resources available to get the patient home. When patients do die in the hospital, like I said, a majority of them do. Sometimes that can be very quick and unexpected. And there are a lot of things about the hospital environment that can be a little harsh. But either way, Child Life can be there to assist in the hospital, make sure that families are feeling supported and cared for. And then the third option for that is dying in a care facility. This could be like a hospice organization or some sort of palliative care place for children that do have terminal or chronic conditions. Ideally, dying in the home or dying in a care facility or hospice place, hospice house, whatever it may be, provides a little bit more comfort to the families, a little bit less of the hustle and bustle of the hospital environment, the bright lights, the constant people, the loud noises, things like that. So in all of those different locations, there are different opportunities for child life specialist interventions, but that is a decision to be made if there is time, like I mentioned. Another decision that needs to be made, that might need to be made at some point, is code status. So kiddos can be placed on DNR, do not resuscitate, or DNI, do not intubate. And for a lot of people, making this decision to make a child DNR or DNI feels like giving up when, as a child life specialist or someone that is trying to support that family, we can intervene and say that it's not necessarily giving up. It's just making the choice that you don't want those specific actions taken on your child. Being intubated or resuscitated can be really traumatic for a patient or family. So if it does come to the point where they no longer want that or the patient no longer wants that, that is something that we might have to help families through. I also talk a little bit about advanced directives, again, planning for the future if time permits, and kind of just getting to know what a child wants, what they want their experience to look like near the end of life, what they want afterwards, how they want to be remembered, and kind of just getting more information, getting to know them better. That's something that Child Life can help with, and we can also help families through that. This can also be somewhat traumatic to think about for parents. They don't expect to lose their child before they themselves die. So it can be difficult, but it is something very important to do, if possible. And then I kind of go into a section about what to expect near end of life. I found this really interesting. I think we should know it, and I think that it's important that we know it so we can communicate with families that these things are normal. So I found some sources about symptoms that are common near end of life, which include decreased appetite, decreased awareness, changes in breathing, slow breathing, skin changes, changes in heartbeat, or pulse, loss of bowel, and bladder control. And then I found some research specifically about end-of-life experiences in pediatric oncology patients. And for them, other symptoms that are pretty common are pain, agitation, delirium, nausea and vomiting, and fatigue. So it's important for us to keep that in mind and assure parents that that's normal, assure patients that that's normal, but also do everything that we can to alleviate those symptoms to the best of our ability. So then I kind of go into misconceptions about end of life. One of those being, unfortunately, the end of life is pain-free. Part of pediatric palliative care is obviously managing pain, and unfortunately, pain and agitation can be present near end of life. So keeping that in mind, making sure that we do tell parents that that's normal, and then on the other hand, and patients obviously, and then on the other hand, advocating for the pain medicine and interventions that are going to work best for the patient. And if those interventions, either pharmacological or non-pharmacological, aren't really helping, we can be there to provide entertainment, distraction, comfort, all of those things. Let's see. The next part that I go into is pretty much just about easing a patient and a family's way throughout this process. So I talk about child life in the care team, and I also talk about spirituality and chaplains. Chaplains are a resource that are pretty common in hospice and end-of-life care. So for child life, I talk about patient support, family and sibling support, and legacy building. So we can be there to get to know the patient, make sure that their wishes are being fulfilled. One case study I read about the importance of child life near end of life talks about a 14-year-old patient and how child life interacted with him, assisted him, his family. They got a magician to come see him often, and because the child life specialist found out that he was interested in magic. It's a cool case study if you want to read it. I also talk about family and sibling support because child life can be there to, like I said, validate parents' feelings, make sure that they're supported, make sure they're connected with the resources they need if they do need other support such as counseling or groups or things like that. And then we can also help them explain to their other children, siblings of the patient, what's going on in a developmentally appropriate way. So depending on their age, we can make sure that they don't have any misunderstandings about death, and we can answer their questions about why their sibling looks different, or why they act different, or why they're not going to be here anymore. Everything like that. Legacy building, we've talked about it in class. I just talked about some examples of legacy building, like foot or handprint art, keeping locks of hair, making shadow boxes, having the child keep a journal or diary if they're able to, things like that. Those are really important because they also serve as keepsakes for the family, but the process of legacy building can be really therapeutic for a family and a patient, and oftentimes it can be an example of a positive memory time that they spent together. I also talk briefly about spirituality and the role of chaplains. Spirituality is important near end of life because a lot of families have specific religious or cultural practices that they associate with end of life that they would want their child to have access to. And that might be being changed into a nice outfit very prior to or recently after death, or being able to wash their bodies so that their soul can transport on to the next place that they think it's going, anything like that. So it's important to validate their beliefs and feelings and wishes and make sure that we're doing everything we can so that those are fulfilled and that they feel like their loved one is getting the treatment that they deserve. And then lastly, I talk about after death because there are a lot of decisions to be made there, and that's just another opportunity for child life to advocate, support, and just make sure that they know that we understand what they're going through is really difficult and that we're there to talk through things, help them. They have so many decisions prior to and during end-of-life care for their child that they might be extremely overwhelmed. And then they have to make decisions about memorials and how they're going to handle those legacy building activities or keepsakes that they made and what's going on with that and how are we going to tell our loved ones and so much. So we can be there to support them through that whole process as well, which can be really difficult. So overall, child life can be there near end of life to support the family, support the patient, and also just to make sure that cooperation and collaboration are happening amongst family members, amongst the care team, making sure that parents and patients feel heard. And I think a really big part of child life is just making sure that families do feel prioritized and cared after. And in that case study I mentioned earlier, finding out that the child liked magic might seem like a small thing, but having that magician go into the patient's room and spend time with them, it helped the patient relax and they had fun. It helped the parents relax and they felt like they were a priority, and that the care team truly cared about them and wanted the best for them because of that. So that's just one example of how child life can help in these situations. And yeah, that is all I have. Thank you.